So come on everybody, let us see liver today. So liver is a, what is that? What is the liver? Liver means? What is liver? It's a gland. Why it is considered as gland? Secretes bile. Any other? So liver is a gland. Could you able to hear? So liver is the largest gland of the body which contains exocrine part and endocrine part. Exocrine means which have the ducts. Okay, ducts. And endocrine means any glands will be releasing the whatever the secretory material directly into the bloodstream. That is called the endocrine part. Okay. Here the exocrine part is nothing but bile. Why? Because it will be evacuated outside through bile ducts, right? Bile ducts. And then endocrine part, the hepatocytes will be releasing after metabolism and everything. It will be releasing glucose and then proteins and then cholesterol also into the bloodstream. So they will not be entering into any ducts over here. They will be directly released into the bloodstream over here. What is it? Carbohydrates, proteins and fats, you can say it as cholesterol over here. Okay. So this part is very much important. Bile belongs to exocrine part of the liver and rest of the carbohydrates, proteins and cholesterol belongs to the endocrine part of the liver. Right or not? Both will not be mixed. There is a blood bile barrier is there. Liver is over or not? Histology? Histology liver over or not? Right? Right? You know the blood bile barrier, right? Bile will be passing through the canalicula, bile canalicula. But through the sinusoids, the blood will be passed over. Okay. Both will not mix together. Okay. So whenever the liver is metabolizing the things, the heat will be released, obviously, isn't it not? When the metabolism is happening, the heat will be released. So that will be maintaining the body temperature, right? And now where the liver is situated, in which region the liver is situated? So right hypochondrium, generally the right hypochondrium, epigastric and left hypochondrium and right lumbar, umbilical and left lumbar and then followed by right iliac fossa, hypogastric and left iliac fossa regions over here. So where the liver is situated? Liver is situated in
right hypochondrium,
entirely the right hypochondrium and upper half of the epigastrium and upper half and till the left lateral margin, left vertical line over here, right? So till this part. Okay, what is that part? Upper half of this left hypochondriac region and it will be only occupying the upper half of the left hypochondriac region and it will be reaching till the so it will be reaching till almost a quarter part of the entire left hypochondriac region. That means this half and this half, like that. Getting it or not? So this half and this half. That's all. Got it or not? So here completely, here only half of the upper part, and then here upper half part, and entire. If you take the entire hypochondriac region, only this part of this vertical part. Got it or not? So this is the occupancy of the liver. Okay. So this thing is very much important. Where the liver is situated, that is very much important. Okay. And then in examination they will ask the weight of the liver also. What is the weight of the liver approximately?
1.4 to 1.7.
Okay. What are the values? 1.5 kg, approximately 1.5 kg in adult males or females generally. And in case of children or newborn, it will be around 150 grams. Okay. This weights will be asked in the examination. So approximately 1.5 kgs in case of adults and 150 grams in case of children. Okay. So liver is covered by a fibrous capsule. What is that?
Listens capsule.
Glissons capsule. Made up of here by this you can understand. So where is the anatomical location of the liver? Right? Right hypochondriac, epigastrium, and left hypochondriac region over here. Okay. So we have seen the weight also over here. How to keep the liver in anatomical position. So how to keep the liver in anatomical position? We'll be discussing a bit later, whenever you understand the rest of the structures over here. Okay. So how this liver is kept in abdomen at this place? What might be the factors which are keeping the liver at this point? That means in the hypochondriac, epigastric, and left hypogastric region, left hypochondriac region. What are the factors? First of all, this is very much important. What are those names? Hepatic veins, and then followed by
Muscles of the
Hepatic vessels.
okay.
triangle.
So these factors are keeping the liver in anatomical position, not anatomical position, exactly at this region or upper region of the abdomen. What are those? First of all, hepatic veins. Where these veins are situated, how these veins are formed? Anybody? Central veins of the liver will be joined together and will be forming the what's the so what's the course or the venous drainage? First of all, into the liver, the blood will be entering through the portal vein. This is our portal vein. That portal vein, along with the mixed blood of hepatic artery, will be draining into central vein. This is our central vein. Whenever all the central veins joining together and form the hepatic veins over. Hepatic veins. So portal vein into the liver. After metabolism and everything, whatever it might be, it will be entering into the central vein of each and every lobule. Each and every central vein will be joining together and will be forming a bigger hepatic vein. Totally, how many hepatic veins are present? 5 or 6. It's okay, fine. So those hepatic veins will be draining directly into the inferior vena cava. They will not be passing through the porta hepatis. Porta hepatis is like a gateway into the liver, just like the hilum of the lung. Okay. But these hepatic veins, for example, the vena cava is present in this manner. Porta hepatis will be roughly over here. Porta hepatis will be over here. If you take on the posterior surface of the liver, porta hepatis will be over here and inferior vena cava will be over here. But the hepatic veins will be coming all the way from the liver and will be joining with the inferior vena cava directly, not through the porta hepatis. So porta hepatis is not the true gateway for the liver. It's not the true gateway for entry and exit of the structures of the liver. Getting it or not? So hepatic veins are draining over here. So these hepatic veins, whenever if this is the inferior vena cava, hepatic veins will be coming all the way and joins with the inferior vena cava in this manner. So liver is over here, and hepatic veins are coming all the way from the liver and joining with the inferior vena cava over here. So this will be holding the entire liver. Getting it or not? So liver is hanged by means of inferior vena cava through these hepatic veins. Getting it or not? This is very much important. Okay. And then triangular ligaments. There are two triangular ligaments, one on the right side and one on the left side. Okay. For example, this is the diaphragm. Everybody understood how the triangular ligaments are attached or not? Peritoneum attached, huh? Sorry, understood, huh? How they are attached? How they are attached? It's okay, fine. See here, these are the two triangular ligaments which will be holding the liver on either sides in this manner, all the way from diaphragm. For example, this is the diaphragm. Okay, so this is the parietal peritoneum. For example, it will be joining with the liver over here and hangs the liver in this manner. So one is the left triangular ligament towards the left side, and one is the right triangular ligament towards the right side. Okay, you will understand that later. Okay. So liver is entirely covered by the peritoneum except few parts. Entirely covered by the peritoneum except few areas. But at the ends of the liver on right and left side, this peritoneum will be going towards the diaphragm and will be continuous with the parietal peritoneum of the diaphragm over here in this manner. Getting it now? So where it is going over here, it will be hanging the liver all the way from the diaphragm over here in this manner. Getting it or not? Right? If you are supposed to hold a kid, you will be holding on either sides in this manner, right? But here in a reverse manner, you will be holding the liver from the all the way from the diaphragm. One is vertical, hanging over here, nothing but from the inferior vena cava. Inferior vena cava is situated just behind the liver, over here. So liver is hanged into the abdominal cavity from the inferior vena cava through hepatic veins over here, and on either sides of the liver by means of triangular ligaments over here. Understood or not? Right. And one more thing, abdominal wall muscles which will maintain the positive pressure within the abdomen, that will be maintaining the liver in position. Okay. Right. But these triangular ligaments and abdominal wall muscles will be secondary, but the hepatic veins are primary things which are keeping the liver in that place over here. So always say how the liver is kept over here. First of all, hepatic veins, and then only anterior abdominal wall muscles and triangular ligaments over here. Okay. So what are the surfaces and borders of the liver? So the liver generally contains surfaces, borders, and lobes and fissures. Okay, generally. Okay. So let us see the surfaces first of all. So first of all, how to keep the liver in anatomical position? First of all, you have to keep the inferior vena cava behind, right? Inferior vena cava will be situated over here. Okay, to keep the liver in anatomical position. To keep the inferior vena cava posterior to the liver. And this border, this is the base of the liver. How the shape of the liver is over here? It is wedge shape. Wedge shape means it will be in this manner. This is wedge shape. Okay. In case of vertebra, there will be wedge compression fracture occurs. So whenever there is a whenever the limbs and trunk are joining together, so this part of the vertebrae undergoes compression, that leads to wedge compression fracture. Okay, that's a different thing. So this is the wedge shape. So obviously the liver is also in the wedge shape over here, right? So what is the apex and base of the liver? This part towards the left side is the apex. If you take this is in the form of a wedge over here. This part towards the left side will be forming the apex of the liver. And this broader edge over here is nothing but the base of the liver. Getting it over? Right. So this broader base must be towards the right side and apex towards the left side over here. And if you see this convexo, concavo, convex superior surface, what is it? Convexo, concavo, convex surface over here will be facing upwards. Why it is so? Convexo, concavo, convexo. Convex surface over here, superior surface, superior surface. Why it is so? What is exactly? Heart. Presence of the heart over here. Because of the presence of the heart, there will be central tendon depression over here. The same depression will be maintained over the liver's superior surface also. Getting it on? So exactly in the middle portion of the superior surface of the liver, above that will be the heart over here. Getting it on? So this part of the diaphragm is nothing but the central tendon, and this is the right cupule of the diaphragm, or the summit of the diaphragm over here, and this is the left cupule of the diaphragm. Okay. And the superior surface, the right part will be a bit above, and the left convexity will be a bit below. Is it not? Right cupular will be a bit above, and left cupular will be a bit below. Right? The same manner, the convexity on the right side will be above compared to the convexity on the left side over here. Got it? So now, this is the important thing. You are supposed to understand the surfaces and borders properly. Okay. Not only theoretically, but practically you are supposed to identify everything clear. Okay. First of all, let us see the surfaces. Okay. What is the surface first of all? This is the liver. Okay. So this surface is obviously facing anteriorly. So it is called anterior surface. There is a surface above, superior surface. And behind that there will be posterior surface. So this surface on the posterior aspect of the liver. This is the right side of the liver, and this is the left side of the liver. Okay. Towards the posterior aspect, this is the posterior surface, and this is the inferior surface. Remember properly, this inferior surface is the widest one compared to the posterior surface. This inferior surface is the widest one. Here only you people will be confusing over here. Okay, I'll make you to understand how to differentiate the both of things, the viscera. Okay. So posterior surface and inferior surface, and one more surface is right lateral surface. Okay, what are the surfaces? Anterior, superior, right lateral, posterior, and inferior surfaces over here. And the borders which are clear over here are the anterior surface, right lateral surface, and superior surface. Come on. So you thought that I was starting late now? No, generally I'm starting late only now. Wait, so you are still in the mood of vacation or what? No. So the anterior surface, superior surface, and right lateral surface will not be having any clear-cut borders over here. Even though the surface is above, the surface is in front, there is no clear-cut border in between the anterior and superior surface, and anterior and right lateral surface, and anterior and superior surface, right lateral and superior surface over here. But there are clear-cut borders on the posterior aspect over here. Okay. So just imagine three semilunar shapes over here to remember. Okay. Three semilunar shaped borders over here. This one is above and posterior aspect. This is the posterior superior border, and this is posterior inferior border, and this is absolutely inferior border. So these are the three borders in the manner of three semilunar shapes over here on the posterior aspect of the liver. Clearly on the posterior aspect of the liver. Okay. One is the posterior superior border, and one is the posterior inferior border, and one is the inferior border, which is the widest one. Where is the inferior border? Do you think that it is from here to here? It is from here to here or what, right? No, it is all the way from here. It will start and goes over here, and it will be ending over here. I will be showing that later on. Okay. So this is the superior border, it should be extending till this part over here, and posterior inferior border will be again from left side towards the right end over here. But inferior border will be starting all the way from here. It will take a turn over here and goes over here towards the left end over here. Get it now? This is the difference, basic difference. Okay. So these are the borders and surfaces over here. Okay. Everybody understood now, right? The borders and surfaces?
Yes, sir.
Okay, this must be understood. Okay. So let us see the surfaces now. First of all, the anterior surface. Okay, anterior surface. It will be related to. Anterior surface is related to towards the right. So this is the entire anterior surface of the liver. The right half is related to the diaphragm, and then followed by ribs over here. What are the ribs over here? 7, 8, 9, 10, and 11 ribs over here. But here one rib will be added over here. 6th rib. Why so? Why so? Where the anterior aspect of the lung ends at the level of the diaphragm? Where? Exactly there. 7 and 8, it's okay. What I'm asking is, on the anterior aspect, the lung will be ending at which rib level? 6th. So obviously it will be extending all the way from 6th to the 10th over here. Is it not? 11th will be a bit posterior. Because it is a floating rib, will not be coming till the anterior aspect. So this anterior half, right half over here. So how the right half is formed over here? There is a falciform ligament which is attached over here. Is it not? There will be a falciform ligament which is attached over here. So this is the right lobe and this is the left lobe of the liver. On the anterior aspect, the falciform ligament will be dividing the liver into right lobe, bigger one, and smaller left lobe over here. Okay. So this anterior surface of the right lobe is related to all the way from 6th to 10th ribs over here. Not the 11th rib. 11th rib will end exactly at this level. It's the floating rib. It will not come on the anterior aspect. Right? So 6th to 10th ribs on the anterior aspect. Okay? And intercostal spaces and the diaphragm, you know very well. Right? So towards the left aspect, towards the left lobe of the liver, you can see this part of this left lobe of the liver is exposed to the anterior abdominal wall. Getting it out? So if any injury occurs directly just below the sternum, the liver undergoes laceration. Laceration means cut. It's okay. Cut is a bit superficial and deeper, right? For example, if you scratch out the skin over here, there will be a cut. That is a abrasion. If you go deeper over here towards the muscles or towards the bone, that is called the laceration. Getting it out? So the deeper injury is called the laceration. Superficial injury is called the abrasion. That's a different thing. So laceration means the liver undergo, that means injury in this manner. If this is the actual substance of the liver, that will be cracked. There will be a crack over here. Okay, that's the laceration. Okay. So the liver will be getting the lacerations because of any injury over here. Getting it out? So this part of the left lobe of the liver on the anterior aspect, anterior surface, will be towards the anterior abdominal wall without any bony cage over here. Getting it out? Right? And then, so this part is deep to the which ribs over here? Which ribs? 7th and 8. Okay, so okay, see here. 6 over here, 7th, 8th, 9th and 10th. Is it not? But here, this part of it below, so you do not include the 6th rib over here. From 7th and 8th, because here 9th, 10th and 10th will be going over here, there is no liver over here. So 7th and 8th ribs will be in contact with the left lobe of the liver of this part. Getting it out? Right part of the anterior surface, intermediate part of the anterior surface, left part of the intermediate anterior surface over here. Right part is absolutely deep to the 6th to 10th ribs over here, and the intermediate part will be just below the xiphisternum, which will be in close contact with the anterior abdominal wall. But this left part will be related to 7th and 8th ribs, but not 9th and 10th ribs over here. Got it, everybody? Right? So this basic difference is important. Based on this only, we will be taking biopsy of the liver and injuries of the liver. We can imagine. Getting it out? Right. So this is about the anterior surface. So what you are supposed to do here is the falciform ligament will be a bit towards the right side of the xiphisternum over here. Getting it out? Xiphisternum will be in the middle. A little bit towards the right side will be the falciform ligament over here. Okay. Right. Coming to this surface. What is the surface here? Right lateral surface over here. So what are the relations of the right lateral surface all the way from outside to inner aspect? Skin, superficial portion, everything whatever it might be, that followed by 7th to 11th ribs. Is it not? Because till what extent will be the lung will be extending over here? Till what level? All the lungs and pleura will be expanding up below towards the costal margin. Very easy, no? 6, 8 and 10, the lung, you add 2 more. 8, 10 and 12. Is it not right? Right? Towards the mid-clavicular line, towards the mid-axillary line, towards the scapular line. It's okay, mid-scapular line, scapular line. Okay. So how it is related over here with the lungs? Lungs will be extending to the water.
6. How about the next? Sorry.
This part is very much important. You're supposed to know all these things over here.
পাশে তো সামনে না দিয়ে তো excellent.
See here properly, everybody. So 7th towards the right lateral surface, it is related to 7th, 8th, 9th, 10th and 11th ribs. Why? Because the lung will be extending till what part rib? 8th part over here. On this side there will be 8th till the 8th. What the rib? The lung will be extending over here, right? Below that, this part is costo-diaphragmatic recess. Costo-diaphragmatic recess. Costo-diaphragmatic recess. This is a space, is it not? So this is the diaphragm and this is the costal thing over here. Costo-diaphragmatic recess, space over here, right? And below that there will be direct contact between the diaphragm and the 10th and 11th ribs and the intercostal space over here. Okay? So this you are supposed to understand. Okay? So here the right lateral surface will be related to 7th to 11th ribs over here. But if you divide it into 3 parts, upper part, intermediate part and lower part over here. So if you are supposed to do a liver biopsy will be done in case of generally cirrhosis of the liver, in case of any, of course, malignancies also you can do. Okay, so what you will do, you will be inserting a needle into the liver and you will be plucking up some part of the liver and you will be putting under the microscope and you will be observing over there, right? So where you can insert the needle all the way from mid-axillary line into the liver over here. For example, if you put the needle over here all the way from here to here, what will happen? Even behind the stomach, what structure is present over here? Spleen, absolutely. If you take 9th and 11th will be over here, which are related to the spleen over here. If you pass a needle to this, you will injure the spleen and later on the stomach will be injured over here. So you can't take from the right side, so left side over here. But from right side, it is clearly exposed towards the exterior aspect, only the liver part. No other viscera will be present over here. Okay, so that you can insert a needle all the way from in which intercostal space you can pass. You have to pass through the mid-axillary line over here into the liver. So through which intercostal spaces? You can pass through mainly through 9th intercostal space and 10th intercostal space. What is it? No problem, what will happen? It will be passing through the skin first of all, superficial fascia, the intercostal muscles will heal, and then followed by the space over here, the pleura is a fibrous tissue, nothing will happen, again it will fibrosis, and then it will be crossing the diaphragm, again muscular but the fibrosis will occur, and straight away it will be reaching the liver. Understanding or not? First if you pass a needle over here, the skin will be there, skin will heal due to fibrosis, superficial fascia again fibrous structure, then followed by the superficial fascia again fibrous structure, then followed by intercostal spaces, again a little bit prick only, that will be replaced by fibrous tissue because of the inflammation and everything, and then further followed by fibrous tissue, again nothing but the pleura, parietal pleura, space and visceral pleura over here, and then followed by diaphragm, and then followed by parietal peritoneum, and then followed by the liver. So everything, if you pass through these structures, everything will be healed by means of fibrosis. No problem will occur, no bleeding, even if bleeding occurs also very minimal bleeding occurs. Okay? So what are the intercostal spaces? So mainly 9th and 10th intercostal spaces through which you can pass the needle into the liver and you can pluck out some part of liver and you will be putting under the microscope. So you can put the needle through 8th intercostal space also, but if you by chance if you put it in this manner, if you will be injuring the liver over here. Lung over here. What will happen to the lung over here? The bleeding occurs obviously. Lung you can't that easily control the bleeding of the lung or the liver. Okay, few structures you can't control the liver bleeding that easily. Okay, so better to go through 9th and 10th, but you can pass through the 8th intercostal space also. Also, this is the secondary choice over here. Okay, second choice. But these two are the primary choices over here. Getting it over? For liver biopsy, you have to pass through 9th and 10th intercostal space, or secondarily 8th intercostal space also. Getting it over? So because the ribs are present over here, if there is any road traffic accident, what will happen to the liver over here? The ribs are present over here, this manner. Ribs are present over here. 6th, 7th, 8th, 9th and 10th. If any lorry or any vehicle hits the patient over here, what will happen? The ribs undergo fracture, and those fractured fragments will be injuring the liver at this point. Okay. But if it hits over here, directly it will hit the liver over here. There is no breakage of the liver or ribs or whatever it might be. And again here, the same. 7th and 8th ribs will be fractured and will be injuring the liver over here. So whenever the liver is injured over here, bleeding will be profound over here. Why bleeding will be profound? Because the veins over here will not collapse. What is it? Hepatic veins which are draining into the inferior vena cava will not collapse. Collapse means, for example, the normal diameter of the vein is in this manner. Collapsing means the diameter will be reduced over here. Getting it or not? The normal veins will be in this manner. So for example, you take in cold climates. Okay, your veins can't be seen clearly because they undergo vasoconstriction, right? So that is nothing but the collapse. Okay, vasoconstriction similar to collapse over here. Getting it or not? Right. So whenever the liver has been cut over here because of the rib fractures, these veins will not collapse or they will not undergo vasoconstriction. Okay, because it's the veins over here, they will not undergo vasoconstriction, so the bleeding will be continuously occurring through the hepatic veins over here. Getting it or not? So injury to the liver is an emergency because of the internal bleeding over here. Getting it or not? Right? So if you insert the needle at the 7th intercostal space, what will happen? Lungs will be injured over. Again, bleeding occurs over. Okay. And if the lung is injured over here, any other thing will occur with respect to the pleura over here. If you some penetrating injury, somebody threw some sharper object towards the right side of the chest, it has passed through the pleura and then entered into the lung over here. So what other effects you can see in case of the pleura? Pneumothorax. Whatever the air which is present in the lung over here will be entering into the pleural cavity, so that will be acting like a what is that? Right? Some valve? No, what is that? What is it? No. That's like a valve. Is it not? For example, the air will be entering into the pleural cavity, but it will not return into the lung over here. It's like a valve. Okay. So that leads to pneumothorax again over here. Not only the bleeding occurs over here, not only the hemothorax over here, but also pneumothorax because of the air which is present in the lung will be escaping into the pleural cavity over here. So these are the consequences if you put the needle through this intercostal space, nothing but 7th intercostal space over here. Understood or not, everybody? Right? So coming to so this is about the anterior surface over here, and these are the injuries what you can expect over here. Okay. And then coming to the posterior surface in between which borders over here? Posterior surface in between which borders? The posterior surface is situated in between posterior superior border and posterior inferior border. And the inferior surface will be in between posterior inferior border and inferior border. So this is the inferior surface and this is the posterior surface over here. Getting it or not? Right. So for the posterior surface to understand, what? We can't clearly differentiate, but by few things you can differentiate. I'll tell you right now. Okay. So how to identify the posterior surface over here? Presence of water. So, okay, first of all, to identify the posterior surface, you have to focus on the groove for inferior vena cava. Okay, just behind the liver, over the posterior surface only, the inferior vena cava will be present over here. Getting it alright? So only posterior surface will be having the inferior vena cava groove, not on the inferior surface, not on the superior surface. Getting it alright? So based on this, you can identify on either side. This is the posterior surface over here. Getting it alright? So what are the other features which are present in the posterior surface? First of all, there is a just beside, towards the left side will be a lobe called the caudate lobe over here. And even beside that will be fissure for ligamentum venosus. Okay, fissure for ligamentum venosus, which contains ligamentum venosus. Basically, it contains ligamentum. It's a fissure which contains the ligamentum venosus, right? Which is a remnant of ductus venosus. It's an embryological thing. You can study later. Okay, fine. Okay. And then further towards the left side will be an impression for an impression for esophagus. That's why don't confuse. Okay. From all the way from inferior vena cava towards the left end over here, you can see first of all inferior vena cava, then followed by the lobe, nothing but the caudate lobe, and then further by fissure for ligamentum venosus, and further towards the left side by means of a groove for abdominal part of the esophagus. What is it? Abdominal part of the esophagus will be present over here. Stomach impression will be present in the inferior surface, not the posterior surface. Remember this properly. Okay. So what is happening with the right aspect of this posterior surface? It contains. What is it, right? Okay. First of all, this will be.
Fissure for ligamentum venosus.
Okay. So here you're supposed to understand properly. Okay. So what you're supposed to understand, see here first of all, imagine that this is the liver over here. Okay, how the liver is covered by the peritoneum you are supposed to understand. Otherwise you can't understand how the bare area and the triangular ligaments over here. Okay. So for example, this is the diaphragm will be in this manner, right? So the liver, the falciform ligament will be going all the way from anterior abdominal to posterior abdominal. Sorry, towards the liver over here. Okay, falciform ligament, right? It is having two layers in this manner. Okay. So this will be the right layer and this will be the left layer. So the right lobe of the liver will be covered by the right layer, left lobe of the liver will be covered by the left layer over here. Okay. But the thing over here is these two layers, for example, you take the right layer alone. Okay, right layer alone, it will be occupying the liver in this manner. Getting it or not? It will be occupying the liver in this manner, right lobe of the liver. So this part will be extending till the diaphragm and hanging the liver in this manner. Getting it or not? So it will be enclosing the liver in this manner. But this part, these two layers over here, this will be extending towards the diaphragm in this manner. Getting it or not? So that will be attached to the diaphragm towards the right side. So in this manner it will be hanging the liver in the abdominal cavity. The same manner, left side also, for example, if this is the left side over here, left side also it will be enclosing the liver in this manner over here. So the upper two parts will not be joining with each other. That will be joined with the diaphragm over here and will be forming the left triangular ligament over here. Got it or not, everybody? Right? Whenever it is leaving a gap over here, this area of the liver on the posterior surface, it is termed as the bare area of the liver. What is it? The bare area. So you are supposed to say the bare area. It's not the, it's the. What's the difference with the and the? No. I tell you, D for the vowels, A, E, I, O, U, D. But the for the other things. Got it or not? D for the A, E, I, O, U, but the for the other things. Got it or not? Consonants. Okay. Okay. Let us see then. It is done as the bare area of the liver over here. The bare area of the liver. What is happening over here? Do you think that the bare area of the liver is having peritoneum or not? Is covered by the peritoneum or not? No. Okay. So that's why it is bare. Okay, bare area. Okay. So whatever this part is not covered by the peritoneum is covered by certain things. What are the things over here? What is it? Glissen's capsule oscillator. If there is no peritoneum over here, the deeper layer will be Glissen's capsule. And here will be the diaphragm over here. In between the diaphragm and the bare area, there will be all the structures will be connected to each other by means of all the structures in the body will be connected to each other by means of areolar connective tissue. Obviously, the diaphragm will be going posterior also in this manner, is it not? The diaphragm will be going posterior and anterior and right side and left side. So here will be the diaphragm in this manner. In between the diaphragm and the bare area, it is filled with loose areolar connective tissue through which right inferior phrenic artery will be passing. You have already seen the phrenic arteries, is it not? The right phrenic artery, inferior phrenic artery will be passing through this part. In between the diaphragm and the bare area, the right phrenic artery will be going towards the diaphragm and supplies it. Getting it on? Right inferior phrenic artery, which is the first branch of abdominal aorta. Okay. So this is about the bare area. So this bare area, above it is bounded by means of upper layer or superior layer of the coronary ligament over here. Okay. Remember this. These two are termed as coronary ligament together. One is the superior layer or upper layer. One is the inferior layer or lower layer of the coronary ligaments. But whenever these two layers are joining together, it will be forming a triangular shaped ligament over here. That is nothing but the triangular ligament over here. Even though these are peritoneum, but the folds of the peritoneum are termed as ligaments. These are not equivalent to the ligaments in the bones based on the density. Getting it or not? It is also made up of fibrous tissue, but it is loose areolar connective tissue. In case of ligaments, it will be dense regular connective tissue. Dense regular collagen fibrous tissue. Okay. So the folds of the peritoneum are called ligaments over here. See here. So this part is superior layer of the coronary ligament. This part is inferior layer of the coronary ligament. When both are joining together, it will form a triangular ligament that will be attached to the diaphragm over here and hang in the liver. Okay. And towards this side also there will be left triangular ligament. Left triangular ligament also will be coming in this manner. Getting it or not? Left triangular ligament also will be joining in this manner. A little bit will be left over here, non-peritoneal over here. Getting it or not? Right? So it will be hanged all the way from the diaphragm. It will be hanged all the way from the diaphragm over here. Right? So this entire rest of the area is covered by the peritoneum over here. But one more thing you are supposed to remember. This caudate lobe is covered by the peritoneum of lesser sac, but rest of the liver is covered by the greater sac. We are supposed to understand. Okay. For example, this is the stomach over here. Okay, I am showing this on the posterior aspect. Okay, now we are discussing about the posterior surface over here. Now we are on the posterior aspect of the liver. This is the stomach. Normally it will be on opposite side. Is it not? Stomach will be normally in this manner. But now it has turned to the right side. Okay. This is the lesser curvature of the stomach. This is the greater curvature of the stomach over here. So behind the stomach will be lesser sac. In front of the stomach will be greater sac, right? So how the lesser sac, what is the extent of the lesser sac over here? It will be extending all the way from above downwards and just behind the stomach. In this manner. Could you understand? Right? So this is a lesser sac behind the stomach, like a balloon for example. The left-sided limiting point will be spleen, of course the gastrosplenic ligament and lienorenal ligament over here. Gastrosplenic and lienorenal, here will be the spleen. So this is the limiting point towards the left side. And the right side it will be limited by means of caudate lobe over here. If you imagine a balloon behind the stomach over here, it will be extending all the way from the spleen till the caudate lobe of the liver over here. Getting it or not? Right? For example, this is the liver over here. For example, this is the liver over here. Okay. Imagine the stomach over here. Behind the stomach is the lesser sac. So lesser sac will be ending at the level of the caudate lobe in this manner, like a balloon. Getting it or not? The narrow part of the balloon will be ending over here, and the wider part will be extending till the spleen over here. And above it will be reaching the diaphragm. Below it will be reaching. Absolutely. What is that? Transverse mesocolon. Could you able to imagine or not? Right? For example, below the stomach there is a transverse colon, is it or not? Behind the transverse colon will be transverse mesocolon. So this is the transverse mesocolon, lower limit for the lesser sac, upper limit is for the diaphragm over here, left limit is the spleen over here, and right limit is nothing but the caudate lobe over here. Could you able to understand or not? Right? It is like a balloon over here. Right? So that balloon will be ending at the level of the caudate lobe. Whatever the rest of the areas of the liver which is present over here are lined by the peritoneum of greater sac, not the lesser sac. This you are supposed to remember. Getting it or not? Understood or not with this part? Getting it or not? Whatever the spaces which are present, because in front of the liver there will be a space which is called the greater sac, that will also be continued behind over here. Getting it or not? Till the lesser sac occurs over here. Lesser sac will be extending till this part above, but in front of this will be the greater sac over here. Getting it or not? Right? For example, if the stomach is present over here. Okay, for example, the stomach is present over here in this part. Okay, for example, this is the stomach over here. Okay, if there is a perforation of the stomach on the anterior surface of the stomach, if there is a perforation because of the ulceration, so there will be leakage of the food contents over here if it is present, or it will be leaking the air. Stomach contains air or not, we will be getting the belching and everything, right? So stomach contains air, so that will be leaked into the peritoneal cavity over here. So where it will reach? It will be reaching the lesser sac or greater sac? Greater sac obviously, because it is in the front, it will be reaching the greater sac which is present in front of the liver over here. Okay, generally if you percuss the liver over the, what is it? Right hypochondrium, it will be which node? Resonant or dull? Dull obviously, because it is a solid, semi-solid sort of. If you percuss over here, it will be dull node. But whenever the air is entering all the way because of the perforation in between the liver and the rib cage over here or the diaphragm over here, that will be filled with the air because of this perforation. So if you percuss, what note you will get? What is it? Resonant. Like if it is filled with the air, it is called hyper-resonant. Getting it out? If it is filled with the air, that's why in case of pneumothorax you will be getting hyper-resonant. It's not a normal resonant, it's a hyper-resonant. Getting it out? So the percussion note will be changed over here based on the presence and absence of the air over here. Got it or not? The same thing occurs with the intestines also. When intestinal perforation occurs over here, intestines also contains the air, is it or not? That air again will be reaching the greater sac in between the diaphragm and the anterior surface of the liver. Again, the note will be resonant note over here. Getting it or not? Right? So this is how the lesser sac will be ending at the level of the caudate lobe. So the caudate lobe alone is lined by the peritoneum of the lesser sac. Rest of the areas will be lined by peritoneum of greater sac. Always remember, this will be the constant and basic viva question over here. Getting it out? Which part of the liver is lined by lesser sac and which is not. Right? See everybody, one more thing you are supposed to understand. So at this posterior surface, there are two layers of the peritoneum over here which are forming the lesser omentum over here. Try to understand this properly, okay? Lesser omentum is having two layers. Is it not? Lesser omentum will be having two layers. What are the two layers? One is the anterior layer and one is the posterior. After the layers of the right layer is occupying everything over here, and after occupying everything over here, these will be going horizontally till the level of fissure for ligamentum venosum. This part is the fissure for ligamentum venosum. So these layers will be enclosing, apart from bare area, enclosing everything over here, and will be reflected all the way from ligamentum venosum and goes towards the stomach over here. Getting it or not? So for example, this yellowish line is the anterior layer of the lesser omentum over here, and this pinkish line is nothing but the posterior layer of the lesser omentum over here. Okay. So what might be this portion over here? What might be this portion? This portion, exactly this portion. Epiploid foramen. So this is the lower end of the lesser omentum. So this is the opening for the epiploid foramen over here. So through which the lesser sac will be communicating with the greater sac in this manner. Getting it down? So whenever you go towards the lower end of the lesser omentum, towards the porta hepatis, this part is the porta hepatis over here. So this area you will be getting the epiploid foramen over here. So what are the boundaries of the epiploid foramen? We'll be discussing a little bit later. First of all, could you even understand about it? These yellowish lines are the anterior layers and the pinkish lines are the posterior layers over here. Getting it on? After enclosing the liver, everywhere the liver is enclosed with this peritoneum over here, then it will be reflected in the manner of lesser omentum towards the stomach and the first part of the duodenum, first half of the first part of the duodenum, or proximal half of the first part of the duodenum. Okay. Right. So these two layers, whenever they are occupying the ligament, what is it? Fissure for ligamentum venosum, that layer will be continued over the porta hepatis in the two manners over here. Getting it or not? So the layers will be going downwards, the layers will be going downwards in this manner, and will be enclosing the porta hepatis in the same manner. Getting it or not? The layers will be going in this manner, and this posterior layer will be becoming the upper margin or upper layer of the porta hepatis, and the anterior layer will be anterior layer of the lesser omentum will be forming the inferior layer of the porta hepatis over here. Could you understand about it? Right? It will be holding, for example, in this manner. Could you understand? So this is the posterior layer which will be forming the upper layer of the porta hepatis, and this is the anterior layer which will be forming the lower layer of the porta hepatis. These are the structures which are entering into the liver and going out of the liver over here. Got it or not? So this is the manner in which the lesser omentum will be joining all the way from liver till the lesser curvature of the stomach over here. Got it or not, everybody? Right? So it is the layers not only occupying in this manner but also occupying in this manner. Got it or not? So you can understand by this. This is the fissure for ligamentum venosum that will be continuing with the porta hepatis over here. So what are the structures which are passing through the porta hepatis now? Exactly. Hepatic artery. See here, from posterior to anterior direction within the porta hepatis, the things which are arranged over here are, first of all, this is the portal vein, and then followed by hepatic artery, and then followed by common hepatic duct, you can see. Okay? Bile duct is a bit bigger one. Okay, hepatic duct, common hepatic. Okay, see properly over here. Through the lower end of the lesser omentum, the structures will be entering or exiting from the liver over here. Try to understand. This upper part will be absolutely free from all these structures, these vessels and ducts, but towards the lower end will be the vein, artery and duct over here. The vein is nothing but the portal vein dividing into right and left venules over here, and then followed by hepatic artery dividing into right and left hepatic arteries, and then followed by the common hepatic duct which is formed by the two hepatic ducts over here. It's the hepatic duct. How the bile will be drained? First one will be the hepatic ducts, two hepatic ducts, then followed by common hepatic duct, then followed by cystic duct, and then followed by the bile duct. Getting it or not? These are the hepatic ducts over here. Then both hepatic ducts, common hepatic duct over here, and then followed by whether it is joined with the cystic duct all the way from the gallbladder over here. Finally, it will be forming the bile duct. This is the absolute pathway. Okay. So all the way from the liver, first for the two hepatic ducts from the two lobes, and then followed by the common hepatic duct for these two hepatic ducts, and the cystic duct will be joined with this, and then forming the bile duct, which will be delivering the things into major duodenal papilla in the second part of the duodenum over here. Got it or not, everybody? Right? So we have to say hepatic ducts and the venules and hepatic arteries over here. Okay. So these are the things which are entering and exiting from the porta hepatis. So you have to say there are two things over here. The branched things you are supposed to say at the porta hepatis, but the lower border of the lesser omentum you have to say the combined things. Nothing but the portal vein and hepatic artery and bile duct you can say that. Get it? Sorry. Common hepatic. Okay. Duct and arteries and veins you can say over here, but ductules and arterioles you have to say over here. Got it, everybody? Right? Okay. So these are at the level of this part, and below this will be the epiploic foramen. What are the boundaries of epiploic foramen? You are supposed to know. What are the boundaries of the epiploic foramen? See here, everybody, we are now looking at the sagittal section over here. Okay, sagittal section or paramedian section at the level of the epiploic foramen over here. Okay, so this is the liver, and this is the same epiploic foramen over here, but behind this will be the vena cava. Why it is side by side over here? Why it is behind it over here? It is like the liver will be in this manner. It's not absolutely horizontal. It will be oblique. Okay. Then porta hepatis will be over here. Inferior vena cava will be over here. So anterior and posterior is situated. But if you turn it absolutely posteriorly, porta hepatis will be over here. Inferior vena cava will be over here. Okay. Because of this oblique tilt, it is antero-posterior. You know? So what are the boundaries of the epiploic foramen which is present over here? Posterior will be the inferior vena cava, and above will be by means of porta hepatis and papillary process of the caudate lobe. We will be discussing that process later on. This is the caudate lobe, this is the papillary process towards the right side, and caudate process towards the right side and papillary process towards the left side. We will be discussing that later. This is the caudate process and this is the papillary process over here. Okay. Among them, the caudate process above and below will be the first part of the duodenum. Could you understand? So these are the boundaries. Imagine the inferior vena cava on the posterior aspect over here, and roof will be formed by the porta hepatis and this caudate process, and below will be the duodenum over here. Could you understand? So this is the upper limit roof, and this is the floor, and this is the posterior wall over here. Got it or not, everybody? Nothing but the inferior vena cava. The boundaries of the epiploic foramen will be asked as a short notes of 2 marks. Getting it or not? So boundaries behind will be the inferior vena cava. Below will be the floor, nothing but the duodenum, first part of the duodenum. Above will be the porta hepatis and caudate process over here. Getting it or not? Right? So it will be present exactly over here. Inferior vena cava will be lying over here, and duodenum will be lying over here. Got it or not, everybody? Understood, everybody? Understood or not, right?
Yes.
No, huh? No? Okay. Okay, I'll show directly in the visitor. Okay, I'll show directly in the visitor. Okay. And then, so these are the impressions what we are going to see on the posterior surface of the liver. Got it or not, everybody? Right? Posterior surface. And then forward to the superior surface, nothing much. It will be having a cardiac impression in the middle. Getting it or not? There will be cardiac impression over here, which will not be lined by the peritoneum again. Try to understand. For example, this is a liver over here. There is a heart over here. For example, this small chalk piece is the heart over here. Getting it or not? Right? So the layers which are coming from the falciform ligament, the right layer will be diverging at the level of the heart over here in this manner. and the left layer will be diverging at the level of the heart in this manner. Got it or not, everybody? So this will be the heart where the two layers will be diverged towards the right lobe of the liver and left lobe of the liver. So wherever the heart is present over here, which is also not covered by the peritoneum over here. So far, how many things which are not covered with the peritoneum? First of all, the bare area of the liver, and then the triangular ligament, right triangular ligament, and then followed by, okay, in the posterior surface, the bare area of the liver, and the fissure, sorry, what is it? Groove for IVC. Okay, let us see that the peritoneum which is not covering the liver on the posterior surface. Okay, anterior surface is absolutely covered by the peritoneum, right and left layers of the falciform ligament over here. Superior surface only at the level of the cardiac impression, it is not covered by the peritoneum, but rest of the areas will be covered by the peritoneum over here. Getting it on? Coming to the posterior surface, this is the bare area. Okay, and then followed by the inferior vena cava groove. Groove for the inferior vena cava is also not covered by the peritoneum over here. So this groove for inferior vena cava acts as a base for the bare area of the liver. Getting it or not? For example, this is the apex of the bare area of the liver. This groove for inferior vena cava acts as a base for the bare area of the liver. Got it or not, everybody? So this inferior vena cava is also not covered by the peritoneum. Okay. Okay, and then followed by, this is covered by, the caudate lobe is covered by the peritoneum or not? Obviously, yes, no, because the peritoneum nothing but the lesser sac, like a balloon, right? Okay, and then followed by, this is a fissure for ligamentum venosum, where two layers are diverging over here. So the floor will not be covered by the peritoneum, but the anterior and posterior walls will be covered by the peritoneum. How it is so? See here, now we are at the posterior aspect of the liver at the level of the fissure for ligamentum venosum, then followed by the caudate lobe, then followed by the groove for IVC, and this is the bare area of the liver. Getting it on? We are at this level. Getting it on? So let us see how it is covered by the peritoneum. This part is covered by the peritoneum of the which sac? Greater sac. That will be reflecting at this part in the form of anterior layer of lesser omentum. So now we are at this point. Now we are at this point over here. So this lobe, left lobe is covered on the posterior surface by means of the peritoneum of greater sac. Till this part. Till this part it is reflecting as the lesser omentum. So that is this layer over here. Getting it on? And then the peritoneum all the way from here will not be covering the bare area of the liver. Okay, for example, the peritoneum. So it is not, the peritoneum is not covering the groove for inferior vena cava over here. Groove for inferior vena cava is also not covered by the peritoneum over here. But see here properly. So this is the lesser omentum over here. Getting it on? This is the anterior layer, this is the posterior layer. Okay. Below will be the epiploid foramen. Okay. So if you consider this is the, for example, this is the caudate lobe over here. This is the anterior wall and this is the posterior wall. Try to understand this. Caudate lobe is situated in this manner. Getting it or not? Because of the obliquity of the liver over here on the posterior aspect. So this is the anterior surface and this is the posterior surface. Try to understand. This caudate lobe will be in this manner. Getting it or not? If you imagine the caudate lobe in this manner, it is not absolutely horizontal, it is obliquely placed. So this becomes the anterior surface and this becomes the posterior surface. Could you able to understand or not? Right? So this is the caudate lobe. Actual caudate lobe will be in this manner. Into the substance of the liver, it will be in this manner. Could you able to understand? Okay. So this part is the anterior surface and this part is the posterior surface. How can I say? It is facing anteriorly, it is facing posteriorly. So this is the vertebrae over here and this is the anterior abdominal wall. This is the vertebrae over here. So towards the vertebra is the posterior surface. Away from the vertebra is the anterior surface over here. Could you understand? Right? So, and this is again anterior wall and posterior wall of this fissure for ligamentum venosum over here. Could you understand? It is not absolutely horizontal. It is not absolutely horizontal in this manner. It is oblique in this manner. So this is forming the anterior wall and this is forming the posterior wall. Getting it or not? Understanding or not, everybody? Okay, this you must know. Okay, this will be asked in the Viva over here. Okay, what are the walls of the fissure for ligamentum venosum and what are the walls for the walls of the caudate lobe over here? Getting it or not? Everybody understood or not? Right? Understood or not? Understood or not? Right? The last guys and girls, understood or not? Right? Right? I will show you in the specimen also later on. Okay. So this is a fissure for ligamentum venosum which contains the ductus venosus. That we will discuss later. Okay. So whenever this is the peritoneum of the greater sac which will be reflected in this manner, and this is the peritoneum of the lesser sac which will be reflected in this manner. You can imagine the lesser sac over here. Here will be the stomach. Here this part will be the stomach, which is covered by the anterior wall in this manner and posterior wall in this manner. Here it will be forming the gastrosplenic ligament over here. Here will be the spleen and again linorenal ligament over here. Kidney over here. And this is occupied by the and goes on. Getting it or not? So this is the lesser sac, this is the stomach for example. In between the stomach and the liver, this is the lesser omentum over here. So caudate lobe is lined by this lesser sac part over here and rest of the areas is covered by greater sac. Anywhere, here or here, apart from the bare area, this part is covered by the greater sac. This part is covered by the greater sac. Only this part, small part in this manner is not covered by the greater sac but by the lesser sac. Okay. So here this lesser sac part is entering into the fissure for ligamentum venosum and again reflecting over here in this manner and forming the posterior layer of the lesser omentum which will be occupying the posterior surface of the stomach over here. Getting it up? And this will be forming as a gastrosplenic ligament over here. Getting it up on the upper part. Okay. Right. Okay. So whenever it is turning over here in this manner, this is the floor of the fissure for ligamentum venosum which is not lined by the peritoneum over here. Try to understand this properly. Fissure for ligamentum venosum and groove for the inferior vena cava, these both depressions are not lined by the peritoneum. Getting it or not? Right? So what are the areas which are not covered by the peritoneum over here? The bare area and then followed by the fissure for ligament groove for inferior vena cava and then followed by floor of the fissure for ligamentum venosum and then triangular ligament, left triangular ligament over here. All these areas are not covered by the peritoneum on the posterior surface. Superior surface only the cardiac impression. Getting it or not? And now coming to the inferior surface, we have energy. Do you have energy or not for the inferior surface? No? Huh? Okay, we'll discuss tomorrow. We'll see the specimen now. Right?
Thank you, sir.
Everybody, shall we see the sympathetic trunk in the post abdominal wall? I forgot to show you in the last.